Okay. Good morning, everyone, and welcome to this breakfast symposium. My name is Mark Menser. I'm the Symposia Chair, and I'm also the CPD Director for CAEP. I'd like to welcome you this morning for dermatologic emergencies with Dr. Kirk Barber and Dr. Vanessa Potok. They've got a large program to get through, and so I want to try and get started so that you can benefit from their wisdom. Please feel free to ask questions throughout. There's two microphones we'll ask you to go to ask your questions, because there was some difficulty with hearing you in this large room. So just make sure if you have the opportunity to ask a question, just try and attend to one of the microphones, and that would be great. I will also remind you at the end to fill in your evaluation forms. There's one on your table as well as one in the app, the CAEP app for the conference. All right, so thank you, and welcome Dr. Barber and Dr. Potok.
Okay.
Good morning, and thank you for joining us so early. Today we'll be speaking about dermatological emergencies. I'm Vanessa Potok. I work here at South Health Campus in Calgary, and I'm an emergency physician trained in BC and Alberta, and I've got a bit of an interest in looking at communication between different specialties and hoping to improve our overall understanding of medicine and medical management of emergencies.
So, and I am Kirk Barber, and we've got some slides we have to run through. This is who I am. I'm at the University of Calgary. I'm a professor there in dermatology. And I'm also cross-appointed with Community Health Sciences, which is an interesting cross-point. And I edit a journal, and I will take the disclaimer now that a lot of the stuff you're going to see is from our journal. Pay particular attention to the references, and I'll bring you a couple and highlight them for you. These are my conflicts. I am very conflicted, and you're welcome to read through them if you want. I won't read them for you. This is my financial support. AbbVie is supporting this symposia, and I am receiving some payment from AbbVie to join you for breakfast this morning. And this is how CAEP mitigated my biases. They tried very, very hard, but I had the last go at the slide deck. So I will be probably using off-label uses for some of the medications we're going to speak about, just so you're informed, and anybody that wants to go can head out the door now if they don't want to hear about it.
All right. And I'm slightly less conflicted than Dr. Barber at this point in my career. But there's still time. As far as financial support, AbbVie did support the symposium, and we did get an honorarium from CAEP as well. And as Dr. Barber mentioned, the CAEP Scientific Committee reviewed our slides, but we did have the final say. So today our learning objectives would be to look at a couple of different dermatological cases, including both more bread and butter types presentations as well as more life-threatening emergent presentations, and understand how to really diagnose these potentially challenging diagnoses here. We're going to look at a number of treatments and discuss when to refer to dermatology as well. So in the emergency, we'll see many kind of skin presentations throughout a day. And a lot of the times this can be quite frustrating. You know, many things look similar. We don't know exactly what the true diagnosis is. We might not know how to treat these properly. And so in today's discussion here, we're going to be looking at a few different similar presentations and knowing how to differentiate them. So let's get started. Just to whet your appetite here a little bit, these are a couple of the cases that you'll be seeing today in your day in the emergency room. So you'll be seeing a few different presentations. Again, some of them a little bit more commonplace and some of them more emergent. Let's start with this little boy. So this is an 8-year-old that comes in with his mother. He's got a history of sensitive skin, but never really had anything similar to this before. So mom says that for the last 2 days, he's had an increase in redness. He's very itchy, and now he has crusting and weeping lesions over his torso, his neck, his face. He's got a past history of asthma, but he's not on any current medications. And he's systemically well, does not have a fever at this point. when you examine him, what you see are erythematous papules, and they're weeping and they're crusted. So when you look at this, what would you want to include in your differential diagnosis? Would you think that this looks a bit like impetigo? Is this HSV? Is this atopic dermatitis? Is this potentially seborrheic dermatitis? I'll give you a couple seconds to maybe discuss it with your table if you like. A lot of these can look similar in presentation. In this particular case, the one that doesn't really fit his picture is the seborrheic dermatitis, but it certainly could be impetigo, HSV, or atopic dermatitis, or it could really be all three. It could be infected atopic dermatitis with both viral and bacterial infection.
All right, so why lead with atopic dermatitis? Well, it's something that's common, it's something that's totally mismanaged, and it's something that occurs in kids, and kids are itchy and uncomfortable and often infected. So it's something that I really would urge you to be very, very aggressive. We go through the treatment program we're going to talk to you about. I would like you, because you're often first point of contact for many of these kids and adults as well that don't have a family doctor. So aggression is the word of the day here, if you would. So it's always itchy. I think the hallmark for atopic dermatitis is always itchy. If it's not itchy, it's not eczema. I think that's a pretty reasonable supposition. And these are the other things that you can see. It always starts early in life, but not at birth. The atopic eczema, constellation of symptoms, signs, asthma, hay fever, eczema, multiple allergies, usually family history. It's chronic, it's relapsing, and usually it starts about 3 months of age. Different presentations, different age groups. The little kids, as in the infants, usually it's extensor face, it's face, extensor arms and legs. As kids get a little bit older, it flips over into the antecubital popliteal fossa. And I think if you're a physician, there's probably a 20 to 25% chance that you're atopic, because it tends to be something that these are brighter kids. These are kids that I see in the nursery, and you walk in and they're watching all the lights, and these bright lights that fascinate them, and they're often misdiagnosed as ADHD. And then in adults, it's hand eczema. And it's common. Many of you have it. Irritated by our jobs, wet, dry. And hand eczema at the Workers' Compensation Board is one of the major disabilities, and time off work has been a big issue for both absenteeism and presenteeism.
So as far as what bacteria would be the most common infection to be kind of concomitant with atopic dermatitis, would it be our group A beta hemolytic strep? Would it be our Staph aureus? Would it be MRSA, or would it be E. coli? So not a trick question. In this case, we are seeing mostly just the methicillin susceptible Staph aureus. Certainly there's more community-acquired MRSA that we're seeing, but far and away the Staph aureus still seems to be the most common one. It certainly can be difficult to diagnose an infection on top of atopic dermatitis. Atopic dermatitis itself can already be crusting and weeping and look quite irritated. So if you're thinking that there might be infection on top of it, you could certainly do cultures, both bacterial and viral. Think about the bacteria being a Staph aureus infection. Viral infections most commonly will be HSV, and you certainly can get both the bacterial, viral together. We'll talk a little bit about eczema herpeticum in a moment here, and that's something that can potentially be life-threatening in some cases, or it used to be anyways prior to the introduction of antivirals.
All right, so difficult to diagnose. The child on your left has primary herpes simplex. The child on your right, atopic eczema. So atopic eczema, inflammatory, weeping, crusting, exudative. Herpes simplex, weeping, crusting, and exudative. And the point I always make when I show this slide is you will be amazed at the number of mothers who do not know that herpes simplex is infectious. They kiss their children on the cheek, and atopics are susceptible viral infection, and they curse this child with this eruption for a lifetime. So it really behooves you to remind everybody you see what the colds are behind your curtains, no matter what they're in to see you about, herpes simplex is an infectious thing. So Vanessa alluded to Kaposi's varicella-form eruption, named after Dr. Kapasi, as you might imagine. This is the typical presentation of herpes simplex and atopic. And the word that you want to take away from this is monomorphous. They all look the same. Okay? Sudden onset, somebody comes in to emerge, sheeted with these things, all look the same. Multiple small inflammatory papules, papule vesicles. Don't need to see the classic presentation. This child has classical bullous impetigo. And I think if you look at the screen, and I won't show you, but in the upper, his left shoulder, you can see little blisters. Remember, bullous impetigo, very superficial cleavage of the stratum corneum. Rarely do you ever see blisters. You just see multiple little erosions. And this is a typical pure Staphylococcal aureus infection in an atopic. This unfortunate kid has both. Okay, so you can see the monomorphous lesions look like, you can imagine that's herpes simplex, but remember herpes simplex is an open wound, bacterial infections are common, staph is common, and went on to progress, right? So in the essence, in the emergency room, culture for both virus and for bacteria. We'll look after it a couple days later when we see them, and then we'll at least have something to treat, and we'll stop whatever is inappropriate, or keep both going. So this child scarred from their infection. So a lifelong reminder that atopic eczema can be a struggle.
So just to reiterate, we are going to see probably a lot of atopic dermatitis in the emergency room. A lot of it is going to be not infected and just simply patients that are frustrated with their management so far and not knowing how to treat their condition. But there can be bacterial and viral infections. Make sure that you do swabs, think about it, and initiate appropriate treatment. And we'll talk about that here, including both topical and oral therapies as needed.
So I reiterate, be aggressive, be aggressive, be aggressive. You're probably, in many instances, one of the physicians that this child in particular, or adults, going to see over their lifetime. Reiterate to them, moisturizing is the key to this. And we think we've worked out some of the immunological and skin barrier defects, but at the end of the day, moisturize, moisturize, moisturizing. Moisturizer, the very, very best moisturizer, is the one someone will actually wear. If you put grease on somebody, they're not going to wear it. If you put cream on other people, it's not going to be enough. So with kids, we let them pick, own it. We give them 4 or 5 choices. They dip, they spread. This one stings, this one burns. The kid owns the cream, and you can be assured that they'll use it if they like it, okay? So no matter what, moisturizing cream is the mainstay. And we all realize now the moisturizing early in life, just like you guys are going through the peanut allergy story, we're going through the moisturize the baby because we can probably prevent atopic eczema. Topical corticosteroids, essential, even over infected skin, okay? We got to get this inflammation under control. We have really good evidence that says if we can repair the barrier, it's as good as putting people on the appropriate anti-infective. So topical corticosteroids are important. Be aggressive. High potency steroids, high to mid potency for sure, if you have a kid that's had a significant flare of their atopic eczema. Calcineurin inhibitors, I'm going to talk about them in a second and their place, but they're really, really important, okay? And the comments you're going to get are, why did the doctor give my baby something that causes cancer? Okay, because in the package insert, it causes cancer. And so you're going to have a rebuttal to that, and there's a rebuttal on the CDA website, but you can say that you heard it here, it does not cause cancer, okay? So just reassure, and I don't know if you guys deal with pharmacists, and my apologies in anticipation of pharmacists being in the room, but I get so many calls from parents saying, the pharmacist told me to do this. Yeah, and I just, okay, but I told you to do that. But the pharmacist said, and then we go through this argument. So I end the argument by saying, just hang on a second. I'm going to go ask my neighbor how I should treat you. Go ahead.
All right.
Oh, I'm sorry, I missed one.
That's
Can you
okay.
see, anybody can see that it's good. They're up front and they respected the reserve tables signs. This is a steroid hierarchy from potent to weak. You don't need to know every steroid. There's over 100 of them. pick one from each category, mild, moderate, and severe. Stick with them. When you prescribe steroids, do it in jars, not in little teeny 15-gram tubes. Base the amount you use on the extent of the skin involvement. And flaring, using topical corticosteroids. Okay? All atopics will go through a flare. When they're flaring, topical steroids and aggressive use of them. As they're better, we use protopic or Elidel creams, which are topical calcineurin inhibitors. The beauty of them is that they're very effective and they don't cause stretch marks. They don't cause stria. There's no worse scene than a 14-year-old girl comes into your office, has stretch marks all over their arms and legs because people kept using potent steroids when she didn't need it. So again, aggressive but smart aggressive in treatments. I wanted to just put this slide in here, not because it's breakfast time and I want to put you to sleep, because I want you to recognize that we probably are as close to having a major therapeutic breakthrough as you can possibly be. You can't get, it's dupilumab is the name of the drug. It is in a cytokine world. It's a monoclonal antibody, and you can get it in adults now. Just in the past few months, it's been in America for a year. We're doing the research trials in the kids now, and we're taking kids. I have kids now that are 12 years old who have been decimated by their eczema, failed school, can't play sports, who are now clear on a once-a-month injection. This stuff's phenomenal, and you're going to see lots of it. And like the psoriasis monoclonal antibodies, the side effect profile is really, really nice. It's minimal. So this slide, to give you an algorithm, I know you guys will be at the top end of this. And as it filters down, we get into other drugs to manage these kids with atopic eczema. So your job, make sure that they're comfortable and early, and use systemic steroids if you need, but get control. We'll look after the long-term control with drugs like the dupilumab or methotrexate or cyclosporin.
So back to our case here with our 8-year-old boy. So in his case, we recommended wet compresses. So this wet wrap therapy is essentially putting on a light, either cotton or gauze wet wrap, 15 minutes on and 45 minutes off for every hour until dry. That can make a big effect within a couple of hours in terms of patient comfort and reducing the pruritus, reducing the inflammation. Lots of emollients. In this case, you could use Vaseline or CeraVe cream, something that the patient will actually use, and then topical steroids as well. So making sure that the class is appropriate for the location and the amount that you're prescribing is appropriate for how much skin they're going to need to cover as well. In this case as well, we were considering that he did have a herpes infection as well as a staph infection on top of his atopic dermatitis. And so he was prescribed cyclovir for 7 days, cephalexin for 7 days, and we should see a resolution of that within 2 days, and that was the case here. And certainly, it's important to get follow-up for these patients, and so within 2 days, 48 hours, your cultures should be back. And in that case, you can decide whether you want to continue therapy or how you'd like to manage your antivirals and antibacterial agents. All right, so our key points in this atopic dermatitis are, certainly atopic dermatitis, bread and butter, we see it every day. Not really life-threatening in most cases, but it can be if there's severe HSV eruption or eczema herpeticum. We need to understand what history has happened for this patient previously in terms of, is this an infection for them? Is this simply a flare of what they've always had? Are they getting appropriate therapy? So getting down to kind of the nitty-gritty of what they've been doing on a daily basis is important for most patients. Make sure that you do swabs, including viral swabs, and consider that they can have a viral and bacterial infection at the same time. And refer to dermatology if you have a severe case or if there's an uncertain diagnosis. Anything to add?
No, we're good. We're good.
Right.
Questions? We're getting our red signal here. We've been well over time on this. Sir? And no. The question was, does it make a difference which one you put on first, the emollient or the steroid? No, it doesn't. Okay, I was taught cortisone first and emollient second. I go to meetings, I speak that, and my colleague says, really? And they put emollients on first, cortisone second. This advantage is, but to get it on. But bathing, we didn't talk about that. Bathing's important, but not as important as creaming. Moisturizing, 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 no soap. No, there's no, you guys are better at this than any other branch of physician, recognizing sick from not sick. And there's a bit of a gestalt to this. Some practitioners will say they never use systemic steroids, dermatologists, right, in managing these kids. And I say probably they're not seeing enough sick kids to warrant it. So if you've got some kid that's been sick for 3 months and is infected, I would recommend that if you're going to use steroids, you cover for the antibiotic though, and the antiviral. All right, sorry, Ron.
All right, so challenge number 2. So you have a 45-year-old patient that comes in. He's had a diagnosis of Crohn's disease for about 10 years or so, and he's been on infliximab, which is a TNF-alpha inhibitor, for about the last 5 years or so, with a good result for his bowel disease. However, he's been complaining of, over the last number of weeks, increasing pain, erythema, and now pustules on his feet. And he comes into the merge wondering if this is infection, wondering what this is in this case. There's a better photograph of his feet and showing the pustules that are on there. So in this case, we don't know much more about his history other than he's on a TNF-alpha inhibitor. He's got a diagnosis of inflammatory bowel disease. And so I know that this is maybe a bit of a difficult question, but what could be part of his differential diagnosis? Would it be an acute psoriasis flare? He doesn't really have a diagnosis of psoriasis to begin with. Is it paradoxical psoriasis? Is this inflammatory eczema? Is this lichen planus? Is this atopic dermatitis for this gentleman? So this is actually paradoxical psoriasis, which is an interesting entity that Dr. Barber will explain a little bit more to us. But it's something that has only really been recognized in the literature in the last number of years here. If we talk about psoriasis, there's the 5 main types that you learn about. Plaque being the most common, your erythematous scale, or erythematous plaque with the silvery scale on top. Then we have guttate, inverse, pustular, and lastly, erythrodermic psoriasis, which is much more rare but can be life-threatening in terms of the fluid losses that they have with it. And paradoxical psoriasis is a little bit different.
So, pus. These people come in to see you with pain walking or pain with their hands working or an atypical kind of rash. And the reason I chose paradoxical psoriasis to illustrate psoriasis is because it's a thing you're most likely to see in someone who didn't know they had psoriasis. Okay, most of the people you're going to see have known history of psoriasis. They come in with a flare of their disease. You know, can you help me? I don't have a doctor. Can you get me in to see the dermatologist sooner? Those kinds of discussions and questions. These are usually people that have inflammatory bowel disease, and they're on a TNF-alpha inhibitor. Or they have rheumatoid arthritis, and they're on a TNF-alpha. And they get pustular psoriasis of their hands and feet, so-called atypical psoriasis or paradoxical psoriasis. So this is the kind of thing you're going to see in your emergency room in someone that doesn't expect to leave with the diagnosis of psoriasis, okay? So a pustular eruption, you're going to culture this because that's what you do when you see pus, but the idea is these people will have it symmetrically, and clearly not something you're going to see as a typical infectious thing. So, pus in the heel, pus in the palms, and that's the localized variant. Just to throw another twist in the tail for guys in emerge, or men and women emerge rather, this is inflammatory pustular psoriasis. These pustules cover somebody's body in a matter of minutes/hours. They wax and they wane. They'll come in, they're very ill, these people. They'll come in, they'll have fever. They'll have that look in their face that says, oh my God, I'm going to die, because they have so much neutrophil enzyme out in their skin, out in their systemic circulation. They have this fear, this fear that they're never going to get better. And they're literally sheets of pus on their skin. Now, it's rare, but it's not so rare you won't see it in your practice lifetime, depending on where you practice. Pustular psoriasis as a group is something that I'm not expecting you to manage. More, I'm expecting you to recognize a couple of different types. The palm and sole type people, these folks will come in and see you because they've had disease for 20 years if they don't have the paradoxical variant. For 20 years, they've had this recurrent inflammatory papulopustular eruption in palms and soles. There's not much you can do for them except to send them to me, use a potent topical corticosteroid to help them through to get to me. Steroid-induced. If you put enough steroid on somebody, on their psoriatic plaques, if you withdraw that steroid too quickly, their plaques will pustulate. They don't have pustular psoriasis, but they have, doctor-generated pustular psoriasis, right? So they've had too potent a steroid for too long. And then we talked about the systemic inflammatory disease. So that's pustular psoriasis, just as a tease for your breakfast. This is something you see all the time, okay? This is something I dare say you have not diagnosed until the patient comes in the second time, right? This is called guttate psoriasis, right? This is raindrop psoriasis. And note that it's of sudden onset, it's generally symmetric, and it's multiple lesions. And this is what each individual lesion looks like, okay? They're red and scaly, not just red. That'll become clear in a minute. So red and scaly, right, for the most part. So what happens is they come in to see you, they have a streptococcal sore throat, you get a throat swab, you put them on appropriate antibiotic, and 2, 3, 4 days later they come back in to see either you or your colleague with a rash. You say, must be an allergy to the antibiotic or to the penicillin, right? And of course it's not, and they have this guttate psoriasis. And if they've never had psoriasis before, they won't recognize it themselves. So this will be, and that is not uncommon, particularly in the younger age group. They might have had a plaque of psoriasis in their scalp, not known about it, not fussed about it, and it's certainly not known as psoriasis if it wasn't in their family. And then boom, they get this shower of papillosquamous lesions, all small, symmetric. So just put that in your mind. Guttate psoriasis, the mimic of a drug reaction. It's not penicillin allergy. All right, how do we manage it? We manage it either with the thought that it's going to go away fairly quickly to you and I is within a few weeks, fairly quickly to a 20-year-old, it should be yesterday. And so we use things like cyclosporin, we use narrowband UVB phototherapy, and topical corticosteroids, but they become a bit useless because of the large surface area that's involved. All right.
All right, so in psoriasis, there are some extracutaneous manifestations. And which ones would those be? Are there ophthalmological abnormalities? Are there joint and arthritic abnormalities? Are there cardiac conditions that can arise as a result of psoriasis, or psychiatric comorbidities? As with kind of leading questions that have an all of the above, yes, this is an all of the above answer as well. And the thing that ties all these together is inflammation and systemic inflammation.
All right, psoriasis, more than just skin deep, right? Psoriasis, when I was growing up, was a skin disease. Now, as my colleagues are growing up, we're finding out it's a systemic inflammatory disease with multiple comorbidities. We're also learning that some of these comorbidities aren't simply psoriatic arthritis, which would come to mind as the most common. This is a study done by a fellow by the name of Joel Gelfand, who's dermatologist, epidemiologist, looked at the GP database in the UK. GP database in the UK is a huge database. It's 600, 700,000 patients. It's a really nice database because physicians are paid to put their patients into this, so the data is relatively good, and so you can rely on the data that's there. And if you look at this piece of data here, the thing I want you to note is the way in the upper left-hand corner is that the incidence of heart disease, of ischemic heart disease, is higher in young men with severe psoriasis than in any other group. So if you have someone that has significant inflammatory psoriasis and they're a young man, they have a significant increase in the incidence of myocardial infarction with that database. That story was first brought out maybe 8-10 years ago now. It's been retold and retold and retold in multiple databases, and now it's very, very clear. We have terrific evidence that not only does psoriasis portend an increased incidence of myocardial infarction, but treatment can reduce that incidence. So again, we're looking at long-term big databases, and so early and aggressive treatment can make a difference to these folks. Arthritis you're quite familiar with. It's something that has been with us now since you've noted psoriasis and you did your internal medicine. The thing about psoriatic arthritis is, in this day and age, we should never, ever see anybody who has significant inflammatory psoriatic arthritis that has caused mutilation. If you see somebody that's got mutilated joints, If I were their lawyer, I'd be recommending they sue their physicians. This is something that should not happen any longer. We have great drugs. We have great drugs that reduce the inflammation. Reduce the inflammation, we reduce the damage to the joint. So early and aggressive therapy. To recognize psoriatic arthritis versus rheumatoid arthritis, remember psoriatic arthritis is a condition where the joint is affected this way, so we can have one joint, versus rheumatoid arthritis is this way, right? Usually it's multiple joints, both hands.
Quick note about uveitis. So certainly psoriasis patients have an increased incidence of that, particularly if you have psoriatic arthritis. Some studies suggest up to 25% of patients with psoriatic arthritis can have some ocular involvement in terms of uveitis. And in that case, if it's axial psoriatic arthritis, it's more commonly anterior uveitis, but if it's peripheral arthritis, then it's more commonly bilateral, so it can be difficult to diagnose as well. And if you have psoriasis and you develop uveitis, that can predict your likelihood of developing psoriatic arthritis as well. So this is something that can be difficult to diagnose in the emergency room, but involve your ophthalmology colleagues in terms of management. Often these are managed jointly with a rheumatologist as well.
All right, so I hope you can appreciate this little figure in the middle of this person's back. Have you heard of the heartbreak of psoriasis? Can you see the little heart in the middle there? Right? So psoriasis often cercinate, has many morphologies. It is commonly treated with topical corticosteroids. So we've done through pustular psoriasis, we talked about erythrodermal psoriasis, we talked about gouty psoriasis, paradoxical psoriasis, but by far and away the majority of psoriasis that anyone's going to see is plaque-type psoriasis. Simple psoriatic plaques, maybe widespread. Most people have psoriasis have probably less than 4 or 5% body surface area. That is 1% body surface area. In the dermatology talk, I know you folks deal in the rule of nines, we deal in the rule of ones, and the idea is 1% is this, right? And so topical corticosteroids, my point of showing you this slide here, typical psoriasis in the scalp, common. Topical corticosteroids, topical corticosteroids, topical corticosteroids. The only thing you have to be aware of is choose your vehicle wisely. If you gave somebody ointment to put in their scalp, they're not going to use it. Now we have foams, we have gels, we have drops. Even cream would work better than an ointment here, right? So ask about vehicle preference, mid to upper strength steroid, applied once a day for sure, because if you say twice a day, you'll probably get them to use it once a day. So the nomenclature is always BID dosing, hoping for one, right? And a more typical, one of our study patients, but a more typical presentation of someone has greater than 10% body surface area probably of psoriasis, right? This person, creaming becomes a little bit more of a challenge, right? So what's the differential diagnosis of psoriasis? For time, I'm skipping it. We're going to get into management. So management is topical corticosteroids we talked about, treat infections if they're present. Cyclosporin, we use a lot of it, interestingly, especially in the acute illness. But really what I want to get on to is this. And we have new biologics, okay? Monoclonal antibodies that we use in managing psoriasis. This is the cytokine pathway, much like the eczema pathway I showed you. So we learned on this pathway. We're now putting it into other inflammatory diseases, atopic eczema being the common one. But what I really want to show you is these new drugs, and if you can find IL-23 on there, that's where we're going. And this is, I put this in just out of one of our papers. The idea here is this drug is an anti-IL-23 drug. PASI 90 means 90% improvement. So we can take somebody with 40, 50% body surface area, put them on one of these monoclonal antibody drugs, get them at least 90% improved. 60, 50% of these people will be 100% improved. We'll never even know they have psoriasis. Now, the downside is they have to stay on their monoclonal antibody, but we've honed this down so tight now that the side effect profile is becoming not only very acceptable, but minimal. I'm going to skip the treatment of paradoxical psoriasis for the sake of time. It's basically topical corticosteroids and maybe changing the person off their anti-TNF.
And just quickly to resolve our case, so our 45-year-old gentleman with inflammatory bowel disease and paradoxical psoriasis, dermatology was consulted and we changed him from the TNF-alpha inhibitor to ustekinumab, which is the IL-23 inhibitor. and he was prescribed Betadine ointment to his affected areas, BID. Pain management was also prescribed in terms of the amount of discomfort that he had in his heels, and pustules were cultured just to ensure that there was no co-infection as well. So our key points for psoriasis are to consider things like paradoxical psoriasis. We're certainly seeing that more often now. Diagnosis is clinical. If you're in doubt, you can always pick up the phone, talk to your local dermatologist. And acute treatment includes topical and systemics, as well as biologics, and don't forget about pain management as well. All right, so your next patient is a 20-year-old female that comes into the emergency asking for an IND of her axillary abscess. She's had 3 abscesses in her axilla over the last 6 months. And when you ask her, she's actually had an abscess in either the left or the right axilla more than 5 times. Oftentimes, though, she doesn't come into the emergency for this. She'll try to manually express them at home. She'll try hot compresses. She's even tried things like pineapple juice or if there's a lot of purulent discharge, she'll sometimes use a menstrual pad to kind of catch the purulent discharge as well. A bit more about her past medical history. She's obese, she's a smoker, and doesn't have any allergies. She's only on an antidepressant. So what's part of your differential diagnosis for this patient here? Is this lymphadenitis? Is this a simple furuncular abscess? Is this LGV, which is a sexually transmitted infection? Is this hidradenitis suppurativa? Is this fistulas in sinus tracts associated with IBD? So in this case, we're talking about hidradenitis suppurativa, or HS. So HS essentially has all those other conditions on the differential, particularly if you're seeing lesions in the groin area. And HS essentially is a chronic, debilitating, inflammatory condition of the apocrine glands of the skin. So you will see it most commonly in the axilla, inframammary, as well as the groin and anogenital region. This is something that patients, unfortunately, are very debilitated by because it's progressive, gets, it usually starts in puberty, gets worse over time, and it can have a lot of social ramifications because of the foul smell, their inability to move their limbs properly if they have axillary or groin lesions. They find it difficult to form relationships and are often depressed as well. So if you're thinking about HS, think about the typical lesions, the location, and the chronicity of it. So again, the typical lesions would be nodules, sinus tracts, abscesses, and scarring. The locations would be those numbers of areas, so the axillary region, inframammary, genital, and lower abdominal are the most common. And to diagnose it, you would have to see it at least 2 times within 6 months, and oftentimes that becomes more and more common as they age. So pre-diagnosis, about 42% of the time we'll see axillary region affected, and 54% of the time the groin will be affected. And once they've already been diagnosed for a number of time, you'll see that the numbers of areas that are affected is increased as well. So by the time they've been diagnosed for a while, oftentimes 87% of patients have groin involvement, 68% of patients have axillary involvement. A couple of comorbidities to think about as well include smoking and obesity. And interestingly, even reducing smoking or quitting smoking can have a beneficial effect for these patients in terms of how their skin looks, as well as losing weight can potentially help as well. So to diagnose HS, think about the lesions, think about the location, and think about the relapses and chronicity, so greater than 2 times in 6 months. So recommended is the statement that essentially is capturing a diagnosis in about 90% of cases. So have you had outbreaks of boils during the last 6 months with a minimum of 2 boils in one of the following locations? Axillary, groin, genitals, under the breasts, or other locations like the perianal, neck, or abdominal regions. So what's the average time to diagnose patients that have HS? Does it take 6 months? Is it a year, 3 years, 6 years, or 8 years? Seems to be actually fairly long and in the region of about 8 years. The reason for that is that oftentimes these patients are quite ashamed of their skin condition and they won't seek care. So about half of the time, or 58% of patients, they wait on average 2.8 years before presenting to a physician the first time. 42% will present immediately, but you don't have the advantage of knowing how chronic their condition has been in that case. And oftentimes it takes many physicians over many visits to get an actual diagnosis. So on average, 5 doctors across 17 visits, and that's why it takes 8 years often to get a diagnosis on average. So what are the most bothersome symptoms for HS patients? Is it pain? Is it decreased mobility in the upper and lower extremities? Is it the purulent drainage? Is it all of the above, or is it something else entirely? So when Dr. Barber and I were discussing this, certainly pain is one of them, but we actually think that it could be something else in this case. Dr. Barber? Oh,
We were discussing it?
we were thinking that, it was more the...
No, it's smell.
The smell.
Smell and sex. Yeah, these are the two things that these people suffer with most, in my opinion. They can't make interpersonal relationships very easily. Can you imagine 8 years, 5 doctors? These people are in such agony, pain, physically, mentally. I can't imagine any other illness where they go misdiagnosed for so long. It has such a significant impact in their life, and 5 doctors have met them, treated them, and removed them from their practices and just said, "Go away. We don't want to manage you." This is a tragedy for us, and one that we're hoping to rectify as we teach people about this condition and how to better manage it. But you're at the forefront. You see these people, you either recognize them or don't. You're the person that has to initiate their triage often and their treatment planning. And these people don't trust you. You might be doctor number 6. And so you got to pay attention. You got to make the diagnosis. You got to say, we'll help you, and go forward. You can make a huge difference to people's lives with this condition.
All right. So once again, the pain or the burning sensation in these patients' skin can be very profound and can be very debilitating. But there's many other symptoms that go along with HS as well. Again, the burden of the embarrassment in not seeking care initially, it can be quite difficult as well. As far as a treatment for HS, there's been many things that have been tried over time, and only now do we have kind of more effective treatments that are not curative, but will be much more helpful for these patients than things that have been tried in the past. In terms of surgical management, oftentimes when these patients come to your emergency with a big inflamed abscess, your first thing might be to want to do an incision and drainage, and you can certainly do that if it's a large inflamed fluctuant abscess. But the problem is that most of these will recur. In fact, there was a study that showed 100% recurrence rate of abscesses within about 6 months for these patients. And so that's when we turn to medical management, and that needs to be used concurrently with any surgical management that's done as well. And so these are the guidelines from Europe. And Dr. Barber, did you want to speak to this a bit?
Yeah, so what you're going to see on these guidelines is surgery up top. Hurley is the type of 1, 2, and 3, as you can imagine, mild, moderate, and severe, as far as disease extent and severity. And this is really a surgeon's disease, but one that the internist should stop the surgeon from being involved in. But at this point in time, if you don't have great surgical backup, you're in big trouble, okay? Because we can, as internists, we can start the anti-inflammatory process, the antibiotic therapy, but we have failed to date to be very helpful, okay? So if you look at the top of that, these are European guidelines, but they have a couple of champions over there who are really working hard on this disease and doing all kinds of work on the comorbidities associated with this condition. And for example, Crohn's disease is probably one of them, right? So we know that this is another systemic illness. So you finish and do your surgery, and as Vanessa's pointed out, we'll show you a little schematic on how ineffective surgery is in long-term management. But when we start to get down in the bottom half of this table, this algorithm, we get into anti-inflammatory therapy, and that's been the use of the TNF-alpha drugs. okay? And right now we have adalimumab, which is the only one of these drugs that is now approved for the management of this condition. And kudos, and I know Avi has paid me, and I'll give you the disclaimer first, but this company has taken a step up, and one of their players has taken this disease and made it her own, and has taught the dermatologist and has done everything she can to get people in the use of this adalimumab for this condition, and finally a one-woman crusade, and now we have significant anti-inflammatory. So with the proper use of adalimumab, we can stop this disease, okay? Now, earlier the better. We may not have a good go at the sort of 30, 40-year-olds that have established disease, but we have a good go at their families, at their kids. And it's disease that travels down families. So we can get a hold of the kids early when, before they saw progressive disease. Now we can make a significant difference. Now, lifelong therapy at the moment, but wow, 8 years, 5 doctors, just keep that in your mind. We think we can stop that. So,
in terms of what we can do in the emergency room, so certainly if there's a big red fluctuant abscess, you can incise and drain it, but this is not the only thing that you should be doing. This is not the standard of care. If there's a nodular area or something that you don't think is really an abscess, it's not really drainable, there has been good effect with a Kenalog or a triamcinolone acetate injection. And so you can take a 10 milligram per milliliter concentration, or even a 40 milligram per milliliter concentration if it's a larger nodule, and you can inject a small amount. So studies have looked at 0.5 to 1 milliliter. You can do that with a local anesthetic such as lidocaine if you would like. Although there has not been a randomized controlled trial, case cohort studies have shown that there has been a significant reduction in the amount of pain that these people experience, a reduction in the amount of inflammatory response that these people have as well. And there won't be as much of a recurrence, they think, as compared to incision and drainage. But again, there has been a head-to-head trial of an IND versus Kenalog injections. The other thing that you can do is begin antibiotic therapy. So both topicals, as we saw in the guideline previously, using 10% clindamycin lotion. That can be applied to the affected areas BID. You can use that, 1% clindamycin lotion, and that can be used along with the 10% benzoyl peroxide to those affected areas. And you can begin a longer-term antibiotic therapy if you're comfortable with that, or refer to your dermatology colleagues at that point, and that would be looking at the tetracyclines, even doxycycline long-term can be something that over a number of weeks can make a significant difference in the amount of inflammation that these people experience. So when we talk about, I'm just going to go back to the slide here. When we talk about incision and drainage, we see a 100% recurrence rate in between 3 to 6 months if you're incising and draining an HS abscess. So unfortunately, this is the patient that's going to keep coming into your emergency department, and that's why this is not the only thing that we should be doing. We should be connecting them with further care in terms of a dermatology referral and anti-inflammatory therapy. For pain management, there's certainly local topical things that you could do, including lidocaine ointments, ice packs, proper wound dressings, but don't be afraid to use a short-term opiate for these people that have really significant burning pain until they get their inflammation under control. So here locally in Calgary, in our emergency rooms, there is a referral form available, and the unit clerk should have that in terms of some of the dermatologists in Calgary that are accepting or kind of interested in HS patients. However, nationally, there is this hsassist.ca database that patients and physicians can use to find dermatologists that are interested in HS and that you can refer to. So just to wrap up HS, it's a chronic debilitating disease. Think about it. If you don't, consider that with a patient with recurrent abscesses, you certainly won't be able to diagnose it. Make sure that you're managing these people's pain. Consider doing a Kenalog injection if they have nodular disease instead of just, striving to kind of find an abscess and incise and drain that. And think about long-term management for these people as well. All right. Yes. Dr. Barber? So any value to chlorhexidine or rinse in that area?
Probably not much. You know, disinfecting the area is not a bad thing, but these are not infectious. These are inflammatory. They can be infectious, of course, in secondary infected, but that wouldn't be one of the mainstays of treatment. Might help with the smell. All right. Challenge 4. From 8 years to 8 doctors, okay? So this patient is going to require multiple physicians. This is an, oh my God, this is a once-in-a-lifetime event. It's a relatively rare phenomena, but even if it's 2 or 3 or 5 or 10 per million, the idea here is that you're all going to see it once or twice in your lifetime. So I recognize some of you are in big cities, some of you are in smaller centers. I want you to think about this condition. I think you probably all got the diagnosis because this is the sort of stuff you guys get trained on at the top. And I really want you to look at that reference. If you have a piece of paper, write it down, okay? This reference, it'll be on multiple slides as we go through. This picture was taken from the journal I alluded to earlier, and this is the Sunnybrook experience with this. They published their protocol for managing these patients in the emergency room and what needs to be done. Now, in Sunnybrook, they have 8 doctors. Your world, you may have 1 or 2, right? So the idea is I'm going to give you some heads up on what's in this document, but really it's worth study. So I'm going to assume that everybody got the diagnosis, but this slide can also serve as the differential diagnosis. It's the toxic epidermal necrolysis, but the word that's been added to this is spectrum. Okay, so over the years we've tried to define this condition, and now we've defined it as TNS, and we've added the word spectrum to it. This is the differential diagnosis, and I'll show you a couple pictures of some of the commoner things that are in differential diagnosis. But basically, these are things that all give significant disease in a very short period of time, many of which cause morbidity and a few mortality. And they all have diffuse cutaneous involvement, some of them blistering, some of them not. This young girl has erythema multiforme. She does not have TENS spectrum. And erythema multiforme, probably viral, not drug. Erythemus edematous plaques. You'll remember the target, and I'll show you some nice pictures in a second of the target, but that's how her face would look like. Commonly, herpes simplex is the trigger to this. This unfortunate little girl has staphylococcal scalded skin syndrome. Okay? So this is a staphylococcal event. These kids peel at the surface. They have a little bit of morbidity, 0 mortality, and of interest, this young girl was a twin, and they both had it, and hospitalized at exactly the same time. That's what your stratum corneum looks like. So this was her skin peeled off. The stratum corneum is so thin that you can hold it up and read through it, okay? And that's what separates you from the rest of the world. In staphylococcal scalded skin syndrome, we just peel off the stratum corneum. In TN spectrum, we peel off the entire skin. SSS doesn't scar. TENS has the potential to scar, and that would be a significant difference. So let's go through the typical patient that has this TEN spectrum. High-risk drugs, relatively recent ingestion, fever, don't feel very well, purpuric erythematous plaques start to develop on their skin, some with mucosal involvement, every one of them with this thing I alluded to before, this prodrome, this sort of pre-death look in their eyes. They're sick, they want to lay there, they don't want to move. So you know that right away that you're in some trouble. You got to have a drug history, and the red flags with drug history are related to you've got one of the drugs that's the cause, and I'll give you a list in a second. 2, you've had fever. 3, it's sudden onset, and you've got some mucocutaneous lesions. The clinical signs. So in defining the spectrum, you do it by percent body surface area. Remember I told you the 1% rule? And we look at TN at anybody that's over 30%. It falls into that spectrum, right? And reason I put histology and immunofluorescence there isn't because it's a difficult diagnosis to make. It's because you want to be sure you make the right diagnosis. So those two things, doing a biopsy and doing immunofluorescence, will rule out that other big list that you saw of differential diagnostic possibilities. This is the list of the drugs, okay? And so common drugs, allopurinol, phenobarb, sulfa drugs, those are the big common ones that have been present and causing this condition for years and years and years. What we're learning is that there is some genetic predisposition, so you can pre-screen if you're using, for some populations, particularly the Chinese population, and they go through that very eloquently in this article. And this is the money slide, okay? So I'm not sure, yeah, you can get a pretty good read of it, but that is the Sunnybrook Protocol as far as what they do straight on, right? Those are the things that they look at, those are the things that they think about when they've made this diagnosis. Okay, so the new and interesting things are not just supportive care, but supportive care is the sort of thing it's in all textbooks. So what is it? Well, supportive care is, not only the fluid and nutritional stuff, but room temperature, keeping the room temperature up. These people lose their skin, and like that picture, they're almost always without any kind of cover because the cover is thick, okay? So simple stuff, right? But the one thing that's sort of interesting and that's new is there's two controversies. One of them is systemic steroids, and you've all heard that, and it's been around for years and years and years. Systemic steroids used early and aggressively may be of some benefit, and I think most centers will probably use it. But nowadays, and the thing that you might want to go back to your ERs and get in stock is a little bit of etanercept. Okay, etanercept is Enbrel, it's a TNF-alpha inhibitor, and this group is now has pioneered this, and now there's more and more evidence coming in where the use of etanercept in 1 or 2 injections during the first few weeks of this illness can make a significant difference to these people's mortality and morbidity. So, supportive care, this is the treatment. You got to stop the drug that's causing it, of course, and I think that goes without saying, but don't be surprised if people keep taking some of these medicines. I had a young girl in, and her drug was minocycline, and as the emergency people are intubating her, her mother says, well, how am I going to give her medicine? And so all through her illness, she's been receiving this minocycline. So it's not just drug, that list, any drug can do it, okay? So any medicine, any rash. I want to go on to this, and we're running a bit short of time to get done because I want to spend some time here. Another reference, unfortunately, a journal that is not quite as eloquent as the journal I edit, but the reference is a very good one, all right? And the reference is one of my teachers, actually. So this fellow is at the Mass General, and he wrote this little piece in, I think, 2012, if I'm not mistaken, and it really is the best look at drug-induced rashes that I've ever read. It's simple, it's quick, and I'll show you his pictures, okay? And you can have a look at these photos in the article. The top two are morbilliform drug eruptions. The one in the left is another morbilliform drug eruption. So usually drug eruptions are sudden onset, symmetric. You can't hardly tell the difference between, in a kid you might think it's a viral exanthem, and in adults you're going to think it's a drug rash. Urticaria is the next one in the middle. You see a sunburn there from doxycycline. The one in the middle and the bottom, that dusky look, is a thing called a fixed drug eruption. This is a very interesting thing. There's only a couple of illnesses that recur in the same location each time. One of them is herpes simplex, and it's always you always think of it as, I get recurrent impetigo. Well, that doesn't exist, all right, in the same location all the time. It's always herpes simplex. And this thing, it's a fixed drug eruption, occur anywhere in the body. Anytime you get the drug, you get the rash. And when you put it together, it's a eureka moment. Things like Tylenol, laxatives, black licorice. There's a list of things that cause a fixed drug eruption. And to tease you, the one in the bottom right-hand corner is measles. And we just don't see that anymore, except if you go to Disneyland, right? And so what we're going to do in our anti-vax world, we're going to start to see more measles. So measles looks like a morbilliform drug eruption, so you got to look for all the other signs and symptoms. These are pictures of the things that you might confuse with this. These are these oh my God moments, okay? So dress, upper left-hand corner, dress. Separated out from the one in the upper right-hand corner, which is your TNS, T-E-N-S rather, okay? The reason is dress needs steroids. It's almost always a drug reaction, and it's inflammatory, it's diffuse, bright red erythema and edema, no blisters. TNS, blisters, okay? So both sudden onset, both drug-induced predominantly, and so drug rash with eosinophilia and systemic symptoms, okay? If you want to go in the bottom left-hand corner, it's called AGIP, acute generalized exanthematous pustulosis. Now, it sounds like something that's rare. It's not that uncommon. It's mostly antibiotic-driven. People come in with a cutaneous reaction that is pustular. And pustular again, but mostly in the flexures. And you get the history of the antibiotics. And then we've got vasculitis in the middle, which I think you would all recognize as palpable purpura, not purpura. Palpable purpura. Got to have the bump to make the diagnosis, right? And then we've got the typical target from the erythema multiforme. So nice representation of pictures, very classic presentation, and a great discussion. And I'm not going to go through and read this for you. This is for you, remind you of the article, differential diagnosis of these things, their characteristics. Very succinct. This is of the serious ones, differentiating dress from Stevens-Johnson's, okay? From AGIP. So, the key points.
So keep in mind a new drug, blistering lesions, mucosal involvement, and fever. These people look sick. We know what sick people look like. You need to involve a multidisciplinary team early. Think about fluid resuscitation in terms of similar to a burn patient with your Parkland formula. Oftentimes we also need to involve ophthalmology, gynecology, urology. These people will end up with conditions such as erythromeatal strictures. They'll have lots of sloughing of all of their mucosa and have a difficult time. So involve your multidisciplinary team early and think about it early as well.
And read the articles. Those two. Take away nothing else. Read those two articles. The Journal of Cutaneous Medicine and Surgery, JCMS. It's listed on the, come up to me and I'll give it to you, right? I'll give you the proper reference. Okay? Journal of Cutaneous Medicine and Surgery. World famous editor. All right, any other questions about that? I'm sure you're going to see it. So read it or know where it is when you can grab it in the middle of the night. Because these people never come in the middle of the day or in the morning. Okay, we have 4 minutes left. What do you want to do?
I don't think we have much time for our fifth challenge. We can just maybe talk about a few quick things with it. So let's talk about bed bugs quickly. So this is not life-threatening. This is bread and butter. We see it all the time. The main thing with this is get a good history. If they do have a large inflammatory reaction, so some people have what's called CRAB, a cutaneous reaction to arthropod bites, and that can be quite significant. You can use a short prednisone taper for them. And some people, because they've been previously sensitized, can have a larger reaction, have more of a urticarial reaction to it, and so consider prednisone for those people. But other than just source control, you don't need to do a whole lot. You can use oral antihistamines. Don't use topical antihistamines because those can be something that people react to as well. Lice, similar story. So you want to do source control, make sure that you do appropriate treatment both when you're first diagnosing it and then 1 to 2 weeks later, treating all household contacts.
This is a diagnosis that we were taught, it was auditory lice. And I was taught that for body lice, because when you open the curtain and you walk into the room, the people have had the homeless folks that had, as it was in Boston, that had their clothes shaken, and all the lice are on the ground, and so you crunch over them. Okay, small joke, but I mean, the guys are awake, yeah, come on. All right, so scabies. If you, itchy rashes, it looks like eczema. Okay, doc, I never had eczema before. Okay, well, it looks like eczema. And I have this saying, if you have a young man in the office or in your rooms who you think has scabies, look at the penis and scrotum. If it's not on the penis and scrotum, it's not scabies. Okay? It's very characteristic. And it's not necessarily the burrows that you see illustrated by the fingers there, but the nodules. They're almost always present on the penis and scrotum. A burrow, typical little burrow there, and this little mite winds its way around. You can have one, you can have two, you can have five, but at any one in time, you probably only have 5 mites on your skin. So it's not a huge infestation, it's the hypersensitivity to that infestation that's the problem, and that's what she looks like. And remind people that they're post-treatment, they're going to be itchy for a few weeks. If you don't, they will come back in and back in and back in until the itch goes away, or God forbid, they'll get these delusions of parasitosis, and you'll be forever cursed. They'll find you, and they'll bring in a little jar of bugs to show you. They'll wait till you're on shift, and then bring you in and show them, okay? So we try not to set people up for these delusions of parasitosis. And the one other thing I wanted to bring up is erysipelas, okay? And I wanted to tell you that it's a hidden diagnosis.